Assalamu alaikum. Inshallah, today we will talk about tibial plateau fractures. Tibial plateau is the articular surface of the upper tibia. Consists of lateral part, medial part, and in between there is intercondylar eminence. The lateral plateau is smaller, weaker, so it is fractured more. Higher, so it will lead to one of the causes of screw home mechanism. Convex, while the medial plateau is the reverse. This is a convex lateral plateau, and this is concave medial plateau. So this plateau is higher than this. So if you want to put a screw from here to there, you have to adjust yourself not to penetrate the surface, because this is higher than this. In dead lateral X-ray, this is the lower surface of the medial plateau, and this is the upper surface of the lateral plateau. Screw home mechanism is due to a lot of factors. Medial plateau is longer in AB and stronger, so that it needs a higher energy trauma to be fractured. And also the medial femoral condyle is inclined outward towards the central axis. Together, and because of the upper tibia, lateral tibial plateau is higher than the medial, some rotation movement occurs during flexion and extension, which produce locking and unlocking mechanism. We will talk about screw home mechanism in detail in total knee, but just medial tibial plateau is stronger, larger than the tibial plateau, lateral tibial plateau, and lower. This is medial femoral condyle inclined inward, leading to, when you extend the tibia, it externally rotate. Extends the tibia, so it is open chain. If you extend the femur, the reverse occur during closed chain. So simply, when you extend the tibia, it externally rotates. Lateral tibial plateau is higher than the medial plateau again. But here, this is the lateral tibial plateau, and this is the medial. This is higher by few millimeter, producing varus alignment of proximal tibial articular surface in relation to the rest of the tibia. So here is about 3 degrees of varus. The proximal medial tibial angle in relation to anatomical axis is about 87. So it is 3 degrees of varus. But as you know, the whole lower limb is valgus. Is in valgus about 6 degrees from where the inferior femoral, the distal femoral lateral angle in relation to anatomical is 81. So it is 9-degree valgus. 9-degree valgus distal articular surface in relation to anatomical axis of the femur. And this is about 3-degree varus proximal tibia in relation to the rest of the tibia. So here is 9-degree, and here is 3-degree of varus. Here is 9 of valgus, and here is 3 of varus. So overall alignment is about 6-degree valgus. This is because of the upper tibia is lateral tibial plateau is higher than the medial tibial plateau. As I inform you, the medial tibial plateau is larger and stronger, so it bears about 60% of the load. So has denser bone. It needs high energy trauma. So if you see a fracture medial plateau, it is sure a high energy trauma. In between is intercondylar notch. Intercondylar notch, this is the medial meniscus, and this is the lateral. Medial meniscus surround the lateral meniscus. So the lateral meniscus attachment is near each other. And this is surround the medial meniscus. So starting by anterior horn of medial meniscus, then the attachment of ACL. So ACL is between the anterior horn of medial meniscus and anterior horn of lateral meniscus. Then the posterior horn of lateral meniscus, then the posterior horn of medial meniscus. Again, medial meniscus surround lateral meniscus. So the lateral meniscus is the nearest part in the middle of the intercondylar notch. PCL is the most posterior part. ACL attachment is between the two anterior horn of the medial meniscus and lateral meniscus, and in between and PCL is the most posterior. I inform you about the intercondylar notch just because if this part is detached, you have to regain it, because of stability of the knee is one of the most important factor to determine the prognosis and outcome of tibial plateau fractures. Also, menisci attached to the plateau by coronary ligament or meniscotibial ligament. Meniscotibial ligament is attached to the menisci, to the plateau. So you have to repair the menisci after reduction of plateau. When you elevate the menisci, as you will see later, to check the reduction of articular surface, you have to reattach this coronary ligament. You have medial collateral, lateral collateral, for sure has a separate lecture, just to inform you that the stability of the knee depends on all of that, both bony, the plateau, and ligaments. Ligaments, which is ACL, BCL, medial collateral and lateral collateral, and menisci. But the menisci in the soft tissue is the most important, so you have to reattach and repair if it is already injured. Also, you have another landmarks for planning your surgical incision. This is the tibial tubercle. This is the Gerdes tubercle, and this is the tibial tubercle. The Gerdes tubercle, iliotibial band attached here. So your approach is coming along this border, just lateral to tibial tubercle about 1 to 2 centimeters, then curved when you reach to the tibial tubercle. And also this is the posteromedial surface of the tibia. This is the posteromedial border or crest of the tibia. So if you need a medial posteromedial approach, it will be along this border. Pathogenesis. Lateral tibial plateau is smaller and weaker, so it is more susceptible for fracture than the medial plateau. Medial plateau is larger and has a denser bone because it bears about 60% of the load, so it is stronger and can't be fractured easily as lateral plateau. And also because of valgus alignment of the lower limb and the direction, usually your leg is headed from the lateral side. This is a medial directed force, making the lateral femoral condyle hitting the lateral tibial plateau, so fractured it. Usually, all lateral plateau fracture usually, if isolated, is a low energy trauma because it is weak. Again, high energy trauma for the tibial plateau, for example by axial forces, will lead to complex tibial plateau fractures. Depression usually occurred in older patients due to osteoporosis, but in younger it will be split for MCQ purpose. Natural history. The key words here in the knee is stability and articular surface. If the stability is good and maintained, articular surface is good and maintained, the prognosis either with non-operative or operative treatment will be good and excellent. But if you lost one of them or both, the prognosis will be bad. Depression means joint incongruity and osteoarthritis. Joint stability depends on bony part, so you have to restore the bone, and ligamentous, but meniscal injury is the most important. Usually, as a general, medial meniscus is more fixed to the tibial bone, so it has no mobility. So it is usually medial meniscus is injured more than the lateral part. But here, the incidence of lateral tibial plateau fracture is more than the medial. So it is more injured in tibial plateau fracture. The lateral is injured more than the medial, because the incidence of tibial plateau, lateral tibial plateau fracture is more than the medial. Of course, if you have Schatzker 4, as we will see later, which is fracture and maybe fracture dislocation of medial tibial plateau, medial meniscus will be injured. Again, 4 could be fracture dislocation, so suspect vascular injury. ACL is usually with the last degree of tibial plateau fracture. Patient history and physical finding for all trauma cases. Proper history followed by ELTS protocol is mandatory. Neurovascular status, open and soft tissue injury compartment syndrome is a vital for all. So what you will do for this case, after proper history including mainly the mechanism to differentiate between low and high energy trauma, and initiating ELTS protocol, and so on. Neurovascular examination is important. Neurology here is the peroneal nerve, dorsiflexion of the foot. Has to be documented pre-op and post-op. And also the vascular state, if you are in doubt about the vascularity, you have to consult a vascular surgeon. All neurovascular status of tissue and compartment syndrome, all this will be had a separate session in details. Compartment syndrome, passive dorsiflexion, induced pain of the foot. Peroneal nerve, dorsiflexion of the foot, either it is lost or intact. Then, for the tibial plateau, ligamentous examination is important, but in real life this is very difficult, and it could be done after fixation. It could be done after fixation. Generally, if you have varus valgus about 10 degree of the knee, this is considered as ligamentous insufficiency, instability, especially varus. Varus is has a very poor outcome than valgus. Your body can't adapt to the varus as valgus. Again, soft tissue. You have to developing your habit in classifying the soft tissue for all trauma cases. Soft tissue could make a big difference. A lot of complication if you ignore this entity. You can wait, if you decide for surgery, you can wait up to 3 weeks until skin wrinkles return. The first classification we have is Schatzker classification. 6 types. 1 to 3 is low energy, involving lateral plateau, and 4 to 6 is high energy trauma. This is type 1 Schatzker, just split in the lateral tibial plateau. Here is a split with depression of the articular surface. If you found the X-ray that the splitting is displaced like this, don't tell me that it is split depressed. It is displaced split. Depression means that there is a depression in the articular surface, not depression in the splitted part. Type 3 is only depression without split. Type 4, as I inform you, is isolated medial, which is stronger, so suspect a lot of soft tissue injury. Could be dislocated knee, and when presenting to you, already spontaneously reduced. Type 5 is bicondylar. As you see, mostly it will be Y-shaped like this, and there is a part of metaphysis already attached to the diaphysis. This is 5. This part is broken in type 6. The metaphyseal diaphyseal junction is broken in type 6. As you see, according to severity. So the question here, this is type 2, split depressed, and this is depressed. How it is more severe than the previous one? Because here, if you want to reduce, it is more surgically demanding, because if you want to reduce this depressed part of the articular surface, you have to open here a window, and with a bone tamp or with the back of a large curette, you can hammering this part and to elevate it. Type 4, is a fracture dislocation. Is a fracture of medial femoral condyle which can be dislocated by, has a different classification, sub-classification to document the associated soft tissue injury. We will talk it in details in knee dislocation later. The most important weakness in this classification, in both classifications, the ignoring soft tissue. And soft tissue is one of the most important triggering for us either to do surgery or not, or to wait, and so on. Imaging, for sure, AB and lateral, oblique, and plateau view. In the part of the knee here, in the surgical anatomy, the plateau is sloping about 10 degrees. So if you want to take a true AB of the articular surface of the plateau, is done by caudally directing the camera to take this 10 degree of sloping, posterior sloping, and this is called the plateau view. This is the X-ray. Stress view practically willing to be done. CT, sagittal and coronal. And for me, the most important is axial. This is the part where a point between the medial and in the intercondylar notch between the medial and the lateral and the medial tibial eminence. This is a point in between. Then to the proximal tibiofibular joint, and this is the posteromedial crest of the tibia. From here to there, this is the posterior column, either posteromedial part or posterolateral part. And this is the tibial tuberosity. This is the lateral column, and this is the medial column. Don't miss a posteromedial column. This is the axial view of the CT. So you need sagittal and coronal and axial CT. MRI, a lot of debate about MRI, but a lot of articles found that MRI changed the classification. MRI add a lot of ligamentous injury, so the protocol of management change. Now, in a lot of trauma centers, MRI is requested for all high energy trauma, tibial plateau. I mean 4, 5, 6. 4 and 5 and 6, we have to order MRI. Again, knee stability is one of the predictor of our outcome. Non-operative management. In tibial plateau, it is multifactorial decision. You have to consider everything, but the key words here is stability, knee stability, soft tissue condition, a lot of factors like patient expectation and so on. So if you have a patient with knee instability and also articular depression, so it is a poor candidate for conservative management. But if it is stable already and with little articular depression, it could be a candidate for non-operative management. For example, minimal depression, less than 3 millimeter in a stable knee, and the patient is a low demand, is acceptable criteria for non-operative management. We use long leg cast or long brace. We wait until clinical and radiological healing to start weight bearing. In this period, you have to do physiotherapy to avoid muscle atrophy. Surgical management is the reverse. Keyword stability and articular depression and soft tissue. Don't hurry for surgery without knowing the soft tissue condition. You can temporize the management with external fixator until soft tissue subside, then go for ORIF, for example. Again, successful outcome, adequate stability to induce early range of motion. Our goals is restore articular surface, so the articular surface has to be absolutely stable fixation and maintain the axis what is the condition of meniscal integrity. If it is torn already, you have to repair in the same setting to achieve good outcome. A lot of options you have, either percutaneous, lag screw, buttressing, or bridging lateral plate, either locked or non-locked. Also, posteromedial fragment, you can go with one fixed with one third plate, or hold it from the lateral side by better locked plate. If you have a bicondylar fracture, you have to start one of other methods is circular fixation, plates and circular fixation. Which is better, plates or circular fixation, like ELattar, for example? Both have the same results if you have the experience to do it. But usually, if it is open and soft tissue is bad, we can go for ELattar. Otherwise, plate is better to avoid the complication of ELattar. For example, a lot of approaches. The main approaches we have: hockey stick or extended hockey stick to detect posterolateral corner, for example, and posteromedial approach for posteromedial fragment. This is the main two approaches. Midline and lateral parapatellar, I don't think that anyone can use nowadays. A lot of complication, a lot of soft tissue stripping. Whatever the approach, we will do submeniscal usually. If it is displaced, we will do submeniscal arthrotomy to see the articular surface reduction. Here we tag the menisci. This is the anterolateral approach or hockey stick approach, and this is the menisci is tagged and elevated to see the articular surface, how I can reduce it. Approaches for the knee will have a separate session, but just simple knowledge. Hockey stick approach, extended part of it is to inspect or posterolateral corner. Posteromedial approach, in the axial CT, if you see a posteromedial fragment and you can't reduce it directly, indirectly you have to open and reduce it directly. Usually the posteromedial approach, this is the collateral part, and this is the posteromedial crest here, and this is the collateral part. Bis anserinius is here, so you open from the posteromedial surface, crest of the tibia, to the medial epicondyle. Usually bis anserinius is cutted and tagged to reduce and buttress the posterior posteromedial tibial condyle. Again, approaches of the knee will have a separate lecture. If you have a bicondylar fracture, you have to start with posteromedial fragment to avoid varus. Posteromedial fragment have to be fixed first. If you put a lateral buttress first, it will be in varus. Sure, will be in varus. Mostly will be in varus. So he will be in prone position, or maybe supine. If prone, then become supine for anterolateral approach. Provisional external fixator or permanent external fixator. Provisional if you waiting for the soft tissue to resolve, then converting to ORIF, or permanent spanning external fixator or non-spanning ELattar, for example. In some centers they do knee arthroscopy. The rule here is to confirm the reduction of the articular surface and document the ligamentous injury, and in some parts of fractures, lateral meniscus could impede reduction. When will you start mobilization? For sure, after clinical and radiological union. What is the principle of management again of the articular surface? Absolute stability. Anatomical reduction and absolute stability. For the articular surface, no rule for relative stability. Anatomical reduction and to do early mobilization. What is this? The question, tell me about your approach to the fixation of this fracture. Don't hurry and answer this question. In real life, you are dealing with a patient, not with X-ray. So again, proper history, ELTS protocol. If the examiner, for example, in real life you have to do this. But if the examiner, for example, tell you, please direct for approach or direct for fixation, it is okay, and be sure and confident that the examiner knowing now that you are a safe surgeon. So for sure he will be smooth in the remaining of exam session. Prove to your examiner that you are a safe surgeon. Be systemic. Proper history, you didn't manage X-ray, you manage a patient. Proper history, proper exam, and so on. This is AB, you need lateral X-ray, you need CT, and so on. Don't hurry and describe and jump for operative management. Tell me about how you would achieve a stable fixation of the articular surface. Usually, as a general rule, a lot of methods after elevation of articular surface, you can use reduction forceps or Spanish, you can use femoral distractor, you can use pins or a combination of them. Then doing a screw, 6.5 partial threaded screw, or if a lot of comminution, you will use a fully threaded screw. Why do you want to achieve absolute stability? Absolute stability is mandatory for articular surface. There is no rule for relative stability. You don't want callus here. What do you, as the surgeon, have to be particularly careful of when use? So when you're using this leg screw, as I inform you, you can use it partially threaded or fully threaded. Be careful not to do a lot of compression. not to cause a narrowing of the articular surface of tibial plateau if you have a lot of comminution. So be gentle. Restoration of the length is our goal, and the axis. How to measure roughly your axis? Intraoperatively, we use a diathermy clamp, diathermy lead from the center of the hip to the center of the ankle. The knee, it should be passed through the center of the knee, roughly. Please avoid varus. Why would you use this one in a bridging mode? This X-ray, you have a lot of comminution here. So this, a lot of comminution, the strain is distributed along this whole area. So you can put a widely separated screw. It will unite. The problem, if it is simple split, you can't do a bridging plate. You have to buttress it and protect the screw after compression. Why? Because there is a small area of splitting. So a lot of strain here, a lot of movement here. It wouldn't unite if you do the principle of relative instability. This a separate lecture, but I want to apply simply here as an introduction. If this was a simple fracture, then how would you use the plate as a protection after compression of the fragment? Then I will put a neutralizing plate or buttressing plate. I put neutralizing to neutralize the force on the screw to avoid its breakage. Why not use a plate in a bridging? It wouldn't unite. In simple fracture, it wouldn't unite. If you have a void, we can use iliac bone graft or calcium phosphate cement. Have the highest compressive strength with lower rate of subsidence. The problem with iliac graft that the plateau is subside. This is the problem. One of other options is ELattar, external fixator ELattar. Usually the wires from the tibial side or from the plafond side, even in the tibial plafond, you put the first wire about 1.5 centimeter away from the articular surface to avoid intra-articular penetration. A lot of invagination of the capsule is handled down and up in the tibial plateau and tibial plafond respectively, and could penetrate intra-articularly and predispose for septic arthritis. What is this? Again, history. Please don't forget history, proper history, ELTS protocol, then going for describing the X-ray and so on. What is this? This is medial tibial plateau fracture after history and ELTS and suspected dislocation. This is high energy trauma. Vascularity is more important than the life of the patient in general is more important than this X-ray. What is the most likely diagnosis? Medial plateau Schatzker 4. What is additional injuries? Everything. All soft tissue can be injured here, and neurology and vascularity could be injured. Thank you so much.